Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio, MD Anderson in San Antonio, Texas. And excited to share with you some of the updates from ASH, and I'll focus specifically on some of the updates as it relates to momelotinib. JAK inhibition has made a big impact on patients with myelofibrosis, with now ruxolitinib approved and fedratinib approved in the United States. Momelotinib is a JAK1 and JAK2 inhibitor that we previously have tested in large phase 3 studies, the SIMPLIFY-1 and SIMPLIFY-2 study. And we subsequently have learned that it also inhibits ACVR1, which has an impact on hepcidin, and we believe is part of the mechanism of it improving anemia in patients with myelofibrosis. So my colleagues, Dr. Vrščáček, myself, and other investigators from the SIMPLIFY-1 and 2 studies presented a couple updates at ASH in anticipation of the ongoing and newly accruing Momentum study. First, we see a strong suggestion that momelotinib likely improves survival in patients with myelofibrosis. With the long-term follow-up data from SIMPLIFY-1, which was in JAK inhibitor-naive patients, and in the SIMPLIFY-2 study, with survivals well in excess of what would have been anticipated for frontline and second-line patients. Second, we see that there is good ability to maintain the dose intensity of momelotinib throughout the course of therapy, particularly in the SIMPLIFY-1 study, as we looked at the dose intensity, which was maintained in the vast majority of patients with momelotinib, and there was frequently underdosing compared to the product label for ruxolitinib. The net is we believe that this is an agent that might play an important role, in particular with patients with anemia. There was an additional analysis which showed that the greatest impact on splenomegaly symptoms and anemia was in individuals with platelet counts of under 300,000, particularly in the head-to-head comparison with ruxolitinib. So it is possible that there may be a slight differentiation in terms of the natural phenotype of patients with myelofibrosis who might be benefiting with one therapy over the other. We are launching now the Momentum study that is accruing globally. This is a study for individuals that have failed ruxolitinib, have significant symptoms, and have anemia. And it's a randomization between momelotinib and danazol with then a subsequent crossover. I'm excited about the JAK inhibitor pipeline. There's not additional significant data as it relates to pacritinib during this year's ASH meeting, but another important JAK inhibitor that is particularly active in patients with a myelodepleted phenotype with marked thrombocytopenia, and this may become available soon. I would welcome a situation where we have 4 JAK inhibitors available for patients, and we're able to look at disease phenotype, perhaps molecular markers in the future, and other clinical aspects in terms of determining which JAK inhibitor to use and when, and then consider the other therapies in the myelofibrosis pipeline, CPI-0610, IMG-7289, navitoclax, MPN inhibitors, imetelstat, and others, and see how they weave into the MF paradigm alone or in combination. I'm excited by increasing options for our patients with myelofibrosis. Thank you.